Welcome. I am Assistant Professor Dr. Farhad Mustafa Musa Atrushi, MD, and today we are going to conduct a clinical review on the diagnostic reliability of anterior cruciate ligament tears. The clinical presentation of this injury is highly consistent. An active patient typically arrives in your clinic reporting a distinct pop in their knee during activity, followed immediately by rapid swelling and a profound sense of joint instability. Biomechanically, this failure occurs when sudden deceleration is combined with a hard pivoting movement. The force of this twisting motion ruptures the central ligament. This instantly compromises the knee's complete structural integrity. If you fail to diagnose this accurately, or if diagnosis is delayed, the mechanical instability of the knee leads directly to secondary complications. The patient will likely develop severe meniscal tearing and progressive cartilage damage over time. Achieving immediate diagnostic certainty preserves the knee's long-term biomechanical longevity. To establish that certainty, orthopedic clinicians rely on three primary diagnostic modalities: the physical examination, magnetic resonance imaging, and finally, arthroscopy. In modern clinical practice, there is a pervasive reflex to bypass bedside skills. Many clinicians immediately order an MRI for any acute knee trauma before laying a hand on the patient. The data tells a different story. A meticulously performed clinical examination rivals, and in specific contexts, surpasses advanced imaging in diagnostic accuracy. We will systematically analyze the statistical data behind the physical exam, MRI, and arthroscopy to build a definitive, evidence-based diagnostic hierarchy. Over-relying on costly imaging without applying clinical skills weakens diagnostic outcomes and resource management. The physical examination is the first-line tool. Its statistical value is heavily dependent on the experience and technique of the clinician performing it. This vector animation demonstrates the anterior translation of the tibia, known as the Lachman test. Systematic reviews show that in experienced hands, the Lachman test achieves roughly 79% sensitivity, with an overall accuracy of 89%. Moving to the pivot shift test, you will note a drop in sensitivity, hovering around 55%. This means it will miss a fair number of subtle or partial tears. However, the pivot shift carries an exceptionally high specificity of approximately 96%. If a patient tests positive here, you can be nearly certain the ACL is torn. Additionally, the lever sign test is another reliable clinical tool, boasting its own 82% sensitivity rate, adding further confidence to the physical assessment. These tests do have limitations. Acute patient pain, severe muscle guarding, or reduced palpable landmarks in highly muscular or obese patients can restrict your physical assessment. Because these maneuvers carry such high accuracy and specificity, the literature confirms that an expert clinical exam should not be skipped in favor of moving straight to an MRI. This brings us to magnetic resonance imaging. It is the most widely used non-invasive modality, and patients often view it as an infallible snapshot of their injury. The meta-analysis data supports its strong reputation. MRI delivers a high sensitivity range of 87% to 98.5% and specificity between 90% and 100%. Looking at this medical MRI slice, we find false positive and false negative rates reaching up to 13%. MRI provides excellent visualization of soft tissues, making it indispensable for identifying associated intra-articular damage like bone bruises and secondary meniscal tears. Logistically, MRI is expensive, and its accuracy remains strictly dependent on the radiologist's interpretive skill. Multiple studies directly indicate that defaulting to an MRI does not inherently yield better diagnostic outcomes compared to a master clinician's hands. MRI serves as a tool for comprehensive assessment and confirmation, rather than the automatic first step for a primary ACL diagnosis. The third and final diagnostic modality is arthroscopy. Returning to our comparative matrix, you can see that arthroscopy is the absolute gold standard of ACL diagnosis, achieving near 100% sensitivity and specificity. It achieves this high level of accuracy by allowing the surgeon direct, real-time visualization of the intra-articular space. But it carries severe limitations. It is a surgical procedure. Utilizing arthroscopy introduces clinical hurdles, including the requirement for anesthesia and the inherent surgical risks and recovery times imposed on the patient. This establishes a definitive clinical rule. Despite its perfect statistical accuracy, arthroscopy is not recommended and should not be used solely for diagnostic purposes. While it offers ultimate certainty, the physiological cost to the patient restricts its use to moments when a therapeutic intervention is already required. To optimize patient care, we must view these three modalities not as parallel choices, but as a sequential hierarchy. This clinical flowchart maps out the standard of care. Step 1 is the clinical examination, a fast and cost-effective first-line assessment tool. Step 2 is the MRI. It acts as the best confirmation tool, utilized specifically when assessing associated intra-articular injuries or when patient guarding obscures your physical exam. Step 3 is arthroscopy. It serves as the definitive reference, but is strictly reserved for when ACL reconstruction or meniscal repair is already planned. Jumping directly to imaging ignores the high specificity provided by physical tests and increases the risk of false positives. Integrating these modalities provides the most comprehensive diagnostic picture, balancing the speed of physical exams with the anatomical detail of imaging. For residents and fellows, technology should augment bedside diagnostic skills. Trust your hands. Master the pivot shift and Lockman tests at the bedside, and use your imaging judiciously to confirm and expand your assessment. Thank you to all my colleagues for attending this clinical review. Thank you so much for your time today.